How are ya? How are ya? Fabulous. Hey, Sam. Glad to hear it, by the way. I like fabulous. Hey, Candy. Hey. Hey, right back at you. Hey, I'm doing really well. I didn't know there was an eclipse today. It wasn't much on Cape Cod. It was 16, 17% coverage. I didn't even know it. I guess I was oblivious. I mean, it got, yeah, it was a total eclipse of the sun today, which I did not know. Tornadoes in northern Illinois. Not good. Yeah, it was visible. Our Icelandic students could have seen it. They would have seen a total eclipse. We got some folks from Iceland in the class. I hope you, yeah, tornado is not a good thing at all. Yeah, hunker down, buddy. So, who's going to be well positioned? Probably not Sam with the weather that's happening there. But who's going to have clear skies tonight to look at the Perseid meteor shower? Anybody? You might. I'm going to try, but it's going to be partly cloudy and then it's going to maybe have some rain later on. But I'm going to give it a shot. I saw one last night, but tonight there's supposed to be 50 to 100 an hour. Yeah, I think you need to seek shelter, buddy. But yeah, 50 to 100 an hour. Somebody's got an open mic. Open mic. Where the hell is it? That you all pass what? Everything? I'll wait till we get later in the program to do that. I'm just happy to see how well you're doing right now. Seriously good. With much to come. And yeah, once you get your mic etiquette down when we get into cardiology, we're going to be having some open mic nights to work on stuff. It is all gas, no brakes. Exactly. And we're going to start pushing down harder on that pedal on the right, too. So, anyway, uh, did last class kind of help you gel some of these meds? Because we're going to do the same thing tonight. Was it helpful for you? You don't have to tell me it was if you didn't think it was. Yeah, good. I know, Sam. Well, at any rate, we're going to do much the same thing. On chapter 15, under amiodarone, it says the onset for the drug is 2 hours. Um, yeah, disregard, Andrew. I don't even know what that was about. Sir, that could be the oral, like if you took the pill, but that's nothing to do with anything. And again, I'm discouraging you to use their data in the book. Okay. Yeah, well, that would be confusing. Use our drug resource guide. That's what you want to do. But yeah, I don't know about that. It must be an oral preparation, I guess. Anybody else with a question on what we've done already before we move ahead? Questions, comments, anything? Well, we're going to start off spending time on the board again, as we did last time. Um, and so, if you all have no questions for me, then let's go ahead and get started. I'll take us over to the blackboard. Get us a going. Okay, so we're going to start off tonight looking at what we refer to as hemodynamically significant bradycardia. It's a mouthful, but it is the phrase. It is the phrase. It describes exactly what we mean. The patient is a bradycardic rhythm, and they are sick because of the bradycardia, right? People can have a bradycardic rhythm and be sick for another reason. We wouldn't treat their bradycardia if they were sick for another reason, right? But if they're sick from the bradycardia, we want to go about treating it. And there are three medications and and pacing, transcutaneous pacing, something you'll learn a lot about. I put this up last time. All people die eventually. Atropine, pacing, dopamine, epinephrine. So that little black humor mnemonic will help you remember medications that we use for bradycardia. All people die eventually. Atropine, pacing, dopamine infusion, epinephrine infusion. We're going to start with atropine uh, in many of these cases. There are, when you get into cardiology and you get more smarts, there will be types of rhythms that are bradycardic where we would prefer to use another approach because we know, based on the specific rhythm or condition the patient's in, that atropine is not going to work for us. But if we're just going for the first generic answer, it would be atropine, and it would be 1 milligram, and that could be repeated at 3 to 5 minute intervals. Please know that the max dose is 3 milligrams, right? 3 milligrams. So 1 milligram is your adult dose. At 3 to 5 minute intervals, you could give up to 3. and no more. Okay. Uh, the dose for atropine is 0.5 to 1. Um, you want to have it be 1 and not 0.5. 0.5 was the old dosing. It still is on my video short in the library on atropine, but the dosing you'll want to know now is 1 milligram, not 0.5. Okay. Uh, transcutaneous pacing. Again, we'll discuss transcutaneous pacing, but we're talking about drugs tonight. Uh, then we have our dopamine infusion. The full dose range is 2 to 20, but we never use 2, 3, 4. We always start at 5, don't we? 5 micrograms per kilogram per minute. So if you wanted to put 5 to 20, because that is our dose range, that'd be fine. But, there is dosing down at 2, 3, or 4. It's just not addressing the receptors that we're trying to address. And in this case, we're looking to what? Increase chronotropy. So we're looking for beta effects, aren't we? So start at 5 mics per kilo per minute, titrate up. Also, the epinephrine infusion. We looked at these for other reasons last time. We looked at them for ROSC, for instance. But here's the epi infusion coming up again. Again, mix 1 milligram, 1 to 1,000 epi in a 250 bag. This is not weight-based, so your dose is going to be between 2 and 10 mics per minute, so not weight-based. So there's your medications for hemodynamically significant bradycardia. You may hear others refer to it sometimes as symptomatic bradycardia, but you get the gist, right? Any questions on that before we move on to the next group of meds? Anything, going once, going twice, going 3 times. Okay. Well, the next group of medications we're going to look at are for acute coronary syndromes. And this is an umbrella that covers everything that could be a reason that the patient has got ischemia in their heart from a problem in the coronary arteries. Now, we kind of looked at this before. We'll be looking at it again, but I want to get our head back in the game here for what is the deal, what happens as coronary artery disease manifests, and then the ultimate would be when there's an MI. And we're going to keep it generic for tonight. But the bottom line is um, we can have accumulation of plaque, and we'll learn in detail later on what constitutes plaque. But it can occupy a lot of space between the lining, the one cell thick lining, which is the endothelium, and the muscle. And it can greatly reduce the opening into the lumen of the vessel. But right now, the endothelial lining is still intact here, right? But now the amount of blood that could flow through this vessel is reduced, and someone who develops symptoms, cardiac symptoms from this, maybe when they increase their activity, or maybe it's after an emotional shock or something, um, that would be stable angina, right? But their chest symptoms, their symptoms are predictable about what would cause them to begin to have them, and predictable as to what works for them to stop the problem. Could just be sitting down, taking a load off, might be taking a nitro, maybe a couple, maybe even up to 3. But in stable angina, the onset of symptoms happens at a predictable time, and what resolves the symptoms happens predictably. But this can go further, as we know. And so let's do another review here. As this plaque becomes more complicated, it will develop a fibrous cap. And this fibrous cap may be quite thick and tough. But what if there's an area of it that's very thin, like you see down the bottom here? That could be vulnerable. So that fibrous cap is protective. What really sets the whole ball rolling is inflammation, right? Inflammation. And it is truly the underlying cause of these bad things happening, right? And there are multiple sources of inflammation. It goes beyond our scope to really dig into that tonight. But it is an inflammatory process that usually precipitates what we're just about to see, which is that this plaque ruptures where it's thin and vulnerable. And that, of course, allows this material to now break through, and it's now inside of the lumen of the vessel, right? So plaque is now actually inside the lumen of the vessel. We've broken through the tunica intima or endothelial lining. This is now officially a wound. And the very first thing that happens is what? You guys tell me. We were the first players that show up on scene. We have a wound now. We've had plaque rupture. Um, before that, all right, Mayor's got it. Platelets, right? The platelets show up, and they start sticking to each other, sticking to the wound surface, and creating what we refer to as a white clot. Okay. And they are also, in addition to sticking to each other and sticking to the wound surface, they're also going to start signaling for the full clotting cascade to unfurl. And when that happens, we're going to get um, fibrin, which was mentioned there, right? Um, so once the entire clotting cascade is unfurled, then you're going to get that fisherman's net we call fibrin. And that's going to trap all the formed elements in the blood, right? Which include the RBCs and everything. And this is what causes the red clot or thrombus to form, right? And if it completely occludes the lumen of the vessel, as I'm trying to demonstrate it doing here, then is any blood going to get past that place? What do you think? No. So this would be the acute myocardial infarction, right? The acute myocardial infarction. Oh, come on now, get my pen back up. Yeah. So that's not stable angina there, right? So we had an unstable plaque. There's a lot of inflammation involved. The plaque ruptured. That tore through that one cell thick lining, the endothelial lining or tunica intima. Immediately, platelets started adhering to the surface and to each other. And then they signal to unfurl the entire clotting cascade, which produces fibrin, the fisherman's net, traps all the formed elements, and forms the red clot. So let us now think about medications and relationship to acute coronary syndrome. And so our first medication, as long as the patient's not allergic to it, is aspirin. Right? And we like to use the baby aspirin, although we don't give aspirin to babies, but those are flavored aspirin, and they're 81 milligrams each. So 81 milligrams per aspirin, right? And we want our patient to chew the aspirin thoroughly. Chew, 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 because the absorption starts to take place right in the mouth, right? Through the oral mucosa, right into the vasculature. So when we have someone chewing the aspirin, we can start getting our desired effect within a very few minutes, honestly. Um, if there are no contraindications for the aspirin, we give 2 to 4 baby aspirin. Many people will just go for 4. But you don't want to give more if they've already taken aspirin before you arrived. They've already maxed out their aspirin dose. Then more is not better. But let's say they have no contraindications. They didn't take any. You would probably go for 4. But 2 to 4 is your dose range. 2 81 milligram aspirin is 162 milligrams. 4 of the 81 milligrams are 324 milligrams. So that's your dose range, 162 to 324 of the baby aspirin. How much is a single adult aspirin? And it's 325, right, milligrams. But if you're giving the 81 milligram aspirin, you are not giving, the adult aspirins are 325 for a single aspirin, right? But don't document 325 because for baby aspirin is only 324, isn't it? And why are we giving aspirin? It's certainly not to address the patient's pain or discomfort. It's because of its effect directly on the platelets, right? It is a platelet inhibitor. In other words, it prevents the platelets from sticking to the wound surface, sticking to each other, creating that white clot, that platelet plug, and then subsequently signaling for the unfurling of the. Um, it becomes a clinical choice, Andrew, and it might be based on something else about the patient, right? So, what was I saying? Um, we're not giving aspirin for pain, right? We're giving the aspirin because it's going to inhibit this platelet activity we just looked at, and then down the line prevent the unfurling of the entire clotting cascade, right? So as long as it's not contraindicated, aspirin is the first medication you want to get on board and get it going, right? Don't be waiting around on the aspirin. Get it going. The next medication that we want to look at for acute coronary syndromes is nitroglycerin. And there are certain things you need to have in place before you give sublingual nitroglycerin. First of all, you need a blood pressure, you need vital signs, right? Secondly, you need a 12-lead ECG. And thirdly, you need a patent IV. So I know some of you are going to say, well, people give nitro to themselves at home and they don't have all that. Well, okay, that's fine. But these are the things we're going to want to have in place before we give nitroglycerin, because obviously patient needs to have an adequate blood pressure. There may be some findings on the 12 lead that makes us maybe use a more nuanced approach. Um, and again, we give nitro to people that don't take it at home that are nitro virgins. And some people will drop their blood pressure. And if you let them crash their blood pressure, it's going to be a lot harder to get an IV on them, right? So you really want to have that IV in place. You need your vitals, and obviously you need that blood pressure. You want a 12 lead. So we can get them chomping on the aspirin. We're assessing them. We're getting the info. We're getting these things in place. And we're thinking about nitroglycerin. The tablets or spray standard dose is zero point 0.4 milligrams. How many micrograms is zero point 0.4 milligrams, by the way? How many micrograms is zero point 0.4 milligrams? 400 mics, that's right. So we want to give this under the tongue, whether it's the tabs or the spray. We can repeat every 3 to 5 minutes, but we do not, in acute coronary syndrome, exceed 3 doses, all right? And we want vital signs after each dose. So if I was just coming up with a slogan, a spiel for nitro, I'd say nitroglycerin sublingual tablets of spray, repeat every 3 to 5 minutes to a maximum of 3 doses with vitals after each dose. That would cover all your bases, okay? And this is some of the stuff you ought to be able to start spieling off, right? These essential piece of information about the medications, how it's given, what's the frequency, if there's any max, and other special considerations. So there you go. Now, in addition to that, we're going to be giving an opiate if the patient is still having discomfort. Now, not everybody has pain. Some people will not describe their symptoms as pain. There are patients who have silent MIs, but some people may describe it as pressure or squeezing sensation, and they don't really consider that to be pain. So you try to avoid using that term, or when you're asking, ask if they're having any discomfort, pain or discomfort, because we want to address that. But for reasons that we'll get more into at a later date, um, morphine is not your best choice. Okay. Now, for some of you, that may be what is in your protocols. So be it. That's what your medical director has selected for you to do. Okie dokie, hokey pokey. But it's not what we're going to be doing here in the school. There are some interactions with the other medications that make it a little more problematic. It's also more likely to drop out the blood pressure, cause vomiting, and so on and so forth. We're going to be in school talking about the fentanyl. Now, some of you may be using Dilaudid instead. So be it. We're not going to be talking about Dilaudid at school. That might be an acceptable alternative. And if that's in your protocols, then so be it, right? But we're going to be talking about fentanyl. We know fentanyl comes on, has got a very quick time to have response. It's almost instantaneous. The patient gets analgesic relief. Our dosing, which you're going to want to learn, is 1 microgram per kilogram to a max of 150 mics. Okay? 1 mic per kilo to a max of 150 mics. So we're using this for its analgesic properties, obviously. But you also get another really important effect, and that is that these opiates will certainly chill you out. And in doing so, they can reduce anxiety, right? They are anxiolytics as well as analgesics. And that's a good thing because people having MIs, they're in some degree of discomfort. They're many times may be very scared. And that means they're going to have a lot of circulating catecholamines, epi, norepi just beating the crap out of their heart, right? And their heart's already sick and ailing and in trouble. So all the fear and anxiety that often accompanies the uh, symptoms of the patient, we want to tamp that down because epi and norepi can really beat the crap out of the heart. And the heart's in the middle of having a big fat MI, maybe, right? So not only do you get analgesic effects, but you also get anxiolytic effects, which can reduce those circulating catecholamines. Anybody have a question on that? Question on the fentanyl and why we use it. All right. Now, there are other medications. And in addition to aspirin, which we've already talked about, right? There are other antiplatelet drugs. So think about the platelets sticking to each other, sticking to the wound surface, right? Something that's going to interrupt the ability for them to do that. And you have drugs like Plavix. They are reprising this drug. Anybody carrying Brilinta? I'll have more to say about these things later. Any takers on Brilinta or Plavix? You are. Is that new for you, Cameron? Just out of curiosity. Is that new to your protocols? Because 2025 ACLS is pushing that like crazy. They want dual antiplatelets. They want to go big or go home, right? You switched to Brilinta a few years ago, but Plavix has been a lot longer. So you don't use Plavix anymore. You just use Brilinta. So you've had it in your protocols for a while then. And do you have a choice between them? That'd be another question, I guess. So Brilinta has a higher rate of people bleeding. I won't get on my soapbox about it tonight, but these these drugs, the Plavix, the Brilinta, there's another one as well. These are the two most common. Um, Plavix is actually a prodrug. It has to process through your liver, and then the metabolites are actually the drug. Brilinta is not a prodrug. It is the drug. No more Plavix. But it does have a higher rate of causing bleeding. And I'm going to tell you there was some backdoor shenanigans that got it up front and center where it is right now to be really pushed so hard in ACLS. And by the way, Plavix and Brilinta do not play well with the morphine. They can cause bad things to happen. This is another thing that nobody is talking about, but boy, is it true. American Heart downgraded the use of morphine in um, ACS, but it's still on their algorithm, and they really are pushing these drugs together, and they are bad combos. So I'm more to say about that another time. There are also these really expensive 2B3A glycoprotein inhibitors, things like Aggrastat, Riopro, and Tegretolin. They're very expensive. Nobody's using them in the pre-hospital setting. But in a hospital situation, they may use one of these. These are all examples of antiplatelet drugs, right? They're preventing the platelet aggregation thing. So the aspirin, then your ADP inhibitors like Plavix, Brilinta, and then ones you'll never see pre-hospitally, the 2B3 glycoprotein inhibitors. But all of these are medications that work to prevent platelet aggregation. AHA is pushing big time for two of these to be given at at the same time, going big on them. All right, what other things might the patient receive in the hospital or maybe in some of your ambulances? Is anybody carrying heparin? It's not a core medication, but some of you may be carrying it, and it may be in some of your protocols to start. Do you give it in ACS, Cameron? You give it to these patients on the way in? And Nolan, you just started. So there may be more systems that start to embrace it. This is not dealing with platelets. This is messing with the blood clotting process. Um, okay, you're seeing it used more often. And you're using it in ACS. That's what I'm confirming. For acute coronary syndrome, it's in your protocols for ACS. So this is specifically to trip up the clotting cascade somewhere else, right? Um, and there's also low molecular weight heparin, which is Lovenox. Some systems might be using that. But again, this is addressing the clot. Now, these things do not dissolve clots, these drugs, but they can prevent the clot from getting bigger, right? Um, you have the ACS box, which includes the Brilinta, the heparin, and the candy Smarties. Okay. So the antiplatelet agents, again, dealing with platelet aggregation, the anticoags are tripping up the clotting cascade. Again, they don't remove clot, they don't dissolve clot, but they prevent subsequent clot from forming or existing clots, preventing them from getting any bigger, or at least that's the idea, right? So those are your anticoags. Now, there are other anticoags that get used, but not for acute coronary syndrome. You've got things like Coumadin, Eliquis, Xarelto, Pradaxa. They certainly get used in patients who are forming clots, but not specifically in acute coronary syndrome. It's all about the heparin, or some may be using low molecular weight heparin, which is Lovenox. And then finally, you've got the medications that literally dissolve the clot, that act like Drano on the clot. And those are your fibrinolytic drugs. When they first came out, they used to call them thrombolytics because they dissolve the thrombus. But it's more technically correct to call them fibrinolytics because they're dissolving the fibrin or fibrin, depending on how you like to say it, right? Uh, and dissolving the clot. And there are three that typically are approved for use in patients with ACS. That would be TPA, tissue plasminogen activator, also known as Activase or Alteplase. But there are two others that are a little faster to give, Tenecteplase and Retivase. These literally dissolve the clot, right? And TNK is Tenecteplase. So some systems where it's long transport times may give these pre-hospitally. Some maybe give them on the way to the cath lab, but ideally the cath lab is better, right? It's preferred, and we'll have a lot more to say about that stuff. Right now, we just want to think about the meds. So for ACS, what have I got here? I've got our aspirin. Let's get that stuff going, right? As soon as possible, as long as it's not contraindicated. Nitroglycerin, you really need Vitals, 12 lead and IV for the nitro. Um, The clot busters, the fibrinolytics, the bigger issue with those, Nolan, is that people can bleed to death anywhere in their body, right? The cath lab is the better choice, but in more remote parts of the country where it's a long distance to a cath lab, if the patient is a candidate for a fibrinolytic, then that may be their only option, right? If they're a candidate. So we get our aspirin on board if it's not contraindicated. Nitro, we need our vitals, our 12 lead, and our IV before we give it. We're going to avoid the morphine. We'll use fentanyl, but some of you may also use Dilaudid. Know your fentanyl dose, though. Not only do we get analgesic properties, but we also get some anxiolysis, which is great to help shut down a lot of those circulating catecholamines. Some of you may additionally be giving another antiplatelet agent like Plavix or Brilinta. Then there also are these 2B3 glycoprotein inhibitors. You won't be giving those. And then some of you are giving anticoags like heparin on the way in, right? Then you've got your fibrinolytic agents. All right. Before we leave, I want to talk about acute pulmonary edema because we do use nitroglycerin there, and we also can talk about Lasix. So you'll certainly learn a lot more about this, but let's do a little preliminary. Um, Acute pulmonary edema, or APE, also known as left ventricular failure. So the patient's developing fluid in their lungs from heart failure, and it is the left ventricle, which is the system pump. That is the one that is failing, right? It's not delivering the blood adequately to the body. And so basically, it can't handle what's being delivered to it. And so we get a congestion happening in the lungs, right? Because the left ventricle receives blood, the left heart receives blood coming back from the lungs. So we got a traffic jam because we can't forward pump. And so we get pulmonary edema. The classic acute pulmonary edema patient, they're tachycardic. Of course, they're tachypnic because they're getting fluid accumulating in their lungs. And classically, they're also hypertensive, right? So this is a pretty classic presentation for the acute left heart failure or acute pulmonary edema. And so what is it that we're trying to do in terms of treatment? Well, if you are having trouble, the left ventricle is too wimpy, it's not able to adequately deliver blood to the body, we want to make it easier for the left ventricle to offload the blood. And what we want to do is to reduce afterload. Now, again, I just said typically the patient will be hypertensive, right? And that increases afterload, makes it harder for the left ventricle to deliver blood to the body because the body is hypertensive. So we use nitro more aggressively to reduce afterload. If you make the tank bigger, lowering the blood pressure, you're reducing afterload. But you also, if you're making the tank bigger, are going to reduce preload, which is the amount of blood returning from the body back to the right atrium. Okay. So you also get a reduction in preload. So the reason we're using nitroglycerin in acute pulmonary edema is for different reasons than we are in ACS. In ACS, we're looking to dilate the coronary arteries, hoping to squeeze a little blood past where that blockade is. Whereas in acute pulmonary edema, we're looking to reduce afterload and reduce preload. And afterload reduction is something that we can monitor because our surrogate is blood pressure, right? We don't want to crash their BP out, but we do want to normalize it. And so we may be much more aggressively administering nitro. And probably, as long as the patient's a candidate, in conjunction with CPAP, right? So CPAP and nitro are the cornerstone for these classic acute pulmonary edema patients. The nitro, again, we're trying to normalize the blood pressure, reduce afterload and preload, so we use it more aggressively. If all you have is sublingual nitro, then you have to break the seal on the CPAP mask to give it, right? But you may be giving double sprays. So again, we're more aggressive. There's no specified upper limit. For acute coronary syndrome, when we're looking to dilate the coronary arteries, we don't give more than 3 nitros, right? Here, you might be giving 5, 6, 8, 10. You're looking to normalize the blood pressure without overshooting your mark, reduce that afterload. So we're much more aggressive with the nitro. Now, I didn't put in the nitro infusion stuff. We'll talk about it another time. Some of you are using IV nitro, and that IV nitro and CPAP is truly a match made in heaven, right? Because you might give your excuse me, you might give your first nitro dose sublingually, maybe double spray under the tongue, and then you get your CPAP going, and in the meanwhile, once you get your IV set up, and transition to, to IV nitro. so you don't have to break the seal on the CPAP. I've got the hiccups, right? You don't have to break the seal on the CPAP mask. So if you have IV nitro that you use in this context, feel free to make self-drug card on it, right? So not nitro and CPAP, great stuff. Now, some of you will still have in your protocol Lasix, which is furosemide. And there are still systems that want you to use it. But quite honestly, it doesn't do much in the acute pulmonary edema patient, uh, except for increase the chance that they're going to end up with an ICU admission, okay? The studies that were done eons ago on it, the reason that they thought it was good is because they thought it made the tank bigger. In addition to its diuretic effects, right? Peeing out extra fluid. But as we know, most of these patients with acute pulmonary edema, the problem isn't they have fluid overload. The problem is the fluid's in the wrong place, right? The fluid is backing up in the lungs. It's not like they just have, generally speaking, too much fluid. Giving Lasix could dehydrate them, which is not actually helpful. So its use has been downgraded. Uh, the vasodilatory effect, as it turns out, really probably isn't really a thing. Uh, they measured it in the arm, like close to where it was injected. And yeah, I know. I'm just going to have to suffer through it here. And hopefully it'll get better. So anyway, they measured it in the arm. There might be local vasodilation, but system-wide, it sounds like it really is an urban legend. And again, it increases morbidity and mortality in patients with acute pulmonary edema. So some of you may have it in your protocols. If you do, so be it. But guess what? It's probably crap. So what about dosing? And I'm just going to give some generic doses. 20 to 80 milligrams IV would be reasonable. So we also looked at acute pulmonary edema. All right, so that's what I've got for you on the blackboard. Let's go look at some slides. All right. So our parasympatholytics, and of course, those are also known as anticholinergics. And the one we're interested in, of course, is our atropine. Our parasympathetic nervous system, as you should recall, is in the largest part controlled by the vagus nerve, the 10th cranial nerve. It controls it's our feed and breathe nervous system. And atropine opposes the parasympathetic system. It basically blocks the muscarinic receptors in the heart, so they can't be stimulated by acetylcholine. So it is a parasympathetic blocker, parasympatholytic. So there's our atropine. So it is certainly an anticholinergic. And as we learned, it's from the berry of the belladonna plant, Atropa belladonna. It is a very potent parasympatholytic. It blocks the acetylcholine receptors. And so since acetylcholine can't stimulate them, basically unplugs the parasympathetic system, and that could be what's slowing down the heart. So it does indirectly then have positive chronotropic effects. So it increases heart rate if the problem is at the level of the AV node and they have an intact parasympathetic system, right? So it's our first drug in many cases of hemodynamically significant bradycardia. Fun night. So once you give it, and you have to give this stuff briskly, you're not slamming it in like adenosine, but you don't want to dilly-dally and lollygag delivering the atropine. You'll actually get the opposite effect. It can cause paradoxical bradycardia if you give it too slowly or you give too little of it. So you want to give it fairly briskly. And again, our dose in adults is what now? Yeah, it's a milligram. So it works pretty quickly. IV peaks in 2 to 4 minutes. And again, half-life, look, it's 2 to 3 hours maybe. But again, we might repeat at 3 to 5 minute intervals. We might give up to 3 doses, or we might decide to go somewhere else. Now, there are other uses for it in toxicology. We'll talk about its use in organophosphate poisoning. But here we want to stick to the script for cardiology. And there's really none in an emergency situation in terms of contraindications for this drug. Again, we're not going to talk about organophosphates, but the top bullet point here is worth commenting on. In certain types of AV blocks, that happen below the AV node that can cause bradycardias, but the source of the problem in the conduction system is below the AV node. Atropine not only won't work on those, but it could make the patient sicker. If the problem that's causing the bradycardia is at the level of the AV node, that's when we think about the atropine. Remember, if someone had way too much atropine on board or had a similar substance, in toxic doses, they would present with this toxidrome. Their pupils would be dilated, so their vision would be blurred. Atropine dries you up, so dry mouth. Um, it can increase heart rate if the problem is too much vagal tone at the AV node. It can cause alterations in mental status, including making people go crazy. So in toxic doses, we talked about the anticholinergic toxidrome: hot as a hair, dry as a bone, blind as a bat, red as a beet, and mad as a hatter. And there are other anticholinergics that could cause this toxidrome uh, in a overdose situation. But our patients will maybe get flushed. It does dry them up. Their pupils can dilate, and you know they might go a little crazy on you. Usually not with the doses we're given, right? So again, for hemodynamically significant bradycardia, 1 milligram IV push every 3 to 5 minutes, max of 3 milligrams. Do not push it too slowly or do not give too small of a dose. It can cause the opposite effect, paradoxical bradycardia. All right. Just going to briefly mention DIGE on the way by. We still see it in people's med lists. It still might be used for certain circumstances in the hospital, but they uh, try not to use it, but it's still out there. Um, and it has an interesting profile. It is a positive inotrope and a negative chronotrope. So when you see it in patients' med list, it may be that it's helping to increase the squeeze for their um, congestive heart failure, or that it is slowing down their rapid AFib. Those are a couple of reasons it might be in the patient's med list still. So either to increase squeeze or to slow down rates. It's not a core drug. It's just one to be familiar with. I'm not going to go big on this, except to say, and you've already encountered this, that people can get toxic on it. The therapeutic and the toxic dose are pretty close together. And many patients that are still taking it may also be prescribed Lasix or another diuretic, maybe Bumex. And that will dehydrate them and make it more likely they get toxic on the DIG. Right? But we talk about DIG because one of the reasons they've tried to get away from it, even though there isn't a modern drug that has uh, the interesting combination of positive inotropy and negative chronotropy that it does, um, is because it can cause a bunch of different dysrhythmias, right? Be the source of a lot of dysrhythmias. So, and it moves more calcium into the cells. That's part of how it works. I'm not going to go into detail here, but dig tox, early signs of dig toxicity. So the patient may just be taking their normal amount, but they've got a little dehydrated thanks to what they're not drinking enough, and their Lasix is dehydrating them. They start getting some GI symptoms, and then yellow or green halos around lights. Those are typical early symptoms, and again, they can cause a whole host of cardiac dysrhythmias. So that's all I want to say about them. If they are not core drugs, I'm not going to spend a lot of time on them. We're just mentioning them on the way by. But here's an image showing you the incredibly complicated clotting cascade, right? And when we talk about anticoags, you're tripping up certain places in the clotting cascade, right? And our interest here is in acute coronary syndrome, but there's certainly other clot situations: pulmonary embolism, deep vein thrombosis, um, embolic or thrombic strokes. Were in a hospital setting, they might be using anticoags. Again, if you carry heparin, I would make a drug card on it and tailor it to what your protocols are. I'm just mentioning it quickly on the way by because some of you may carry it. It's not a core drug for you to learn if you don't carry it. But the point, again, is to prevent a clot from forming or prevent an existing clot from getting bigger, okay? And I'm not going through the pharmacology of it. There is a subcutaneously injected low molecular weight form of heparin called Lovenox. It's another type of heparin. I really thought my hiccups would be gone by now. So that's all I'm going to say about that. Uh, again, many of you are not carrying fibrinolytics pre-hospitally, but you need to know all about them. It's certainly not a core drug for you to no front and center unless you carry it. One of these. But these are the clot busters, right? They dissolve the clot. But because they dissolve clots, they have a big risk that comes with them because they can make the person bleed anywhere, right? But this is one strategy to open up that plugged coronary artery and try to stop the MI. The time is muscle, right? The more the time goes by, the more loss of the muscle. Preferentially, getting the patient to the cath lab is the better approach. But again, um, location, location, location for some of you who work in more rural areas and especially out west. So the big ones are TPA, which is activase or alteplase, retiplase, and tenecteplase. But there are other fibrinolytics. Streptokinase is an old one. I'm not sure how much they use that anymore. We'll mention them again later, but just mention them on the way by. Here's our aspirin. Again, it prevents platelet aggregation. As a medication, it is an NSAID, and it does have anti-inflammatory properties, that's for sure. But again, the reason we're using it is in ACS is for its platelet inhibition, right? How does it work? And it works on the COX enzyme pathways. There's a COX-1 pathway and a COX-2 pathway. Did I have that slide in here? Yeah. Let's look at this first. So you've got the COX-1 pathway here, which is what we're interested in. And if you block this substance called thromboxane A2, you cannot make the product. So it messes with this process, and therefore the platelets will not aggregate. So it blocks that ability for platelets to aggregate. Aspirin specifically works on the COX-1 enzyme. Aspirin, it downregulates thromboxane A2, prevents the formation of thromboxane A2. That you should know, right? That's something you should know. Things like the Plavix, which is clopidogrel, or prasugrel or taclopidine. These are your ADP inhibitors. Brilinta's over here as well. And they work on a different mechanism, but they still prevent platelet aggregation. Then you've got the 2B3A glycoprotein inhibitors, which again are very expensive in the hospital. They work on the activation of the 2B3A receptors, right? The blocks thromboxane A2 is what you need. Okay. So it blocks the formation of thromboxane A2, which causes platelet aggregation, also causes vasoconstriction. This is another thing that aspirin may do a little bit, is transiently dilate the coronary artery. We know that's why we're using nitro, but you may get a little of that dilatory effect as well from the aspirin, which is interesting, right? But this is why we're giving it. Okay. So 5 minutes, if they're chewing it really well, they're going to start getting antiplatelet effects within a very few minutes. All right. But again, if they've already had aspirin, giving them more is not making things better. Okay. And again, we want the 81 milligram flavored aspirin. So much easier for them to tolerate and chew and all that stuff, right? We don't give aspirin for stroke in the field because we don't know if it could be a bleed, right? You got to scan their head. So that wouldn't be something we do in the pre-hospital. Certainly, there are people that are allergic to aspirin. You need to inquire about that. If they've got a big old bleeding ulcer, you might want to back off a bit. Certain asthmatics, but not all asthmatics, will have aspirin allergies. People that have what's called atopic asthma or intrinsic asthma may also have an allergy to aspirin. So, like any medication, we want to ask about allergies and potential contraindications, right? Every time you take an aspirin, it makes your stomach bleed a little bit. It is an NSAID, a non-steroidal anti-inflammatory drug, but it is the only NSAID that we use for acute coronary syndromes. We don't use Motrin or Aleve or any of those things, right? And again, more is not better. And its antiplatelet effects will last for a couple of days or more. What are some side effects? Heartburn, again, GI bleeding, could cause nausea and vomiting. Someone who is prone, it could cause wheezing, and it does, because of its effect on thromboxane A2, can prolong the time to make a clot, right? Because it's messing with those platelets. We don't mix it with other NSAIDs, and we don't want to mix it with antacids. Aspirin is acetyl salicylic acid, and if you gave an antacid, you would basically cancel out the effect of the effect of the aspirin. Right. So 162 to 324 milligrams chewed. All right, I'm not going through these fibrinolytic agents, but here's streptokinase. Again, it's going to dissolve the clot. We're going to look at a fibrinolytic checklist, and here it is. Sorry, it's small. You can go full screen if you need to. You know, the full screen button over in the upper right. But this is one specifically for MIs, and they may all be a little different. But the bottom line is, anyone who is a potential candidate, they have to be ruled in or ruled out because the side effects in the wrong patient can be death from bleeding out. So this is no joke, right? Because fibrinolytics dissolve clots and they indiscriminately dissolve clots. So, what are some things that are on the checklist to see whether or not a patient would be a candidate for a fibrinolytic? And first of all, is blood pressure. If their systolic or diastolic is too high, they will not be a candidate because that could increase the chance they could bleed in their brain, right? Have a hemorrhagic stroke event. If that's the only contraindication, and they can give medication to lower the blood pressure, that might make them a candidate. Okay, but hypertension, and again, these are the parameters. Systolic greater than 180, diastolic greater than 110, no go on the fibrinolytic. Checking the blood pressure on the right versus the left arm. If there's a difference of 50 millimeters of mercury or more, that's highly suggestive of a patient with a thoracic aortic aneurysm, a big ballooning out of the aorta up in the thoracic area. Depending on where that aneurysm is, it may be impacting the blood flow to one arm versus the other. So unequal pulse strengths, blood pressures varying right to left arm. Step away from the fibrinolytics because that's a pretty good indicator they may have an aortic aneurysm up in the thorax. History of structural central nervous system disease, maybe little aneurysms up there, maybe it's a big malformed artery venous globby thing on AV malformation, anything that could predispose for them to bleed in their brain. Significant closed head or facial trauma within the last 3 months. Recent, within 6 weeks, major trauma, surgery, including LASIK surgery for the eye, GI bleeding. These are all contraindications. Bleeding or clotting problems. Are they on anticoags? If they're on anticoagulants, they are not going to be a candidate. They've had CPR for greater than 10 minutes. Pregnancy, certainly a contraindication. And then other serious diseases where they may be in a terminal state already. Uh, and you're going to find slight variations on the specific questions, but they're all targeted to rule out patients that could bleed to death if given one of those fibrinolytic drugs, right? And that rules out a bunch of patients who just wouldn't be candidates. So I'm not going through all the details on them. Obviously, if you carry one, then you should make a good drug card on it. But here's absolute contraindications: active bleeding, suspected aortic aneurysm and dissection, traumatic CPR, severe persistent hypertension, recent head trauma or known intracranial tumors, history of stroke in the last 6 months, pregnancy, so on and so forth, right? Then there are relative contraindications as well. So, a little bit on them. Any questions or comments on that stuff? Again, I don't want to hyper focus on anything but the core drugs for us tonight. Well, let's move on then, and let's look at sodium bicarbonate because it is a core drug that you're going to need to learn. Do we use it that often in cardiology? No, but there are times when we might. So we certainly need to be highly familiar with this medication. It comes in a big 50 ml syringe. It's measured only in milliequivalents, which, as we learned, has to do with combinability of electrolytes. So it's not measured in milligrams or grams, only in milliequivalents. And there's 50 milliequivalents in 50 milliliters, so it's 1 milliequivalent per milliliter. It is a sterile solution of basically baking soda, an 8.4% solution in sterile water. Okay, and I think we all know it's going to elevate the pH. It's an alkalizing agent, and it adds buffer. Right, it adds buffer here. So you recognize our acid base equation here. Right, so it elevates the blood pH. It's certainly not a first line medication in cardiac arrest. Back in the 70s, it was. Think about this from what you know. They would give epi and bicarb and alternate. What do you know about epinephrine and alkaline solutions? Do they play well together? No. So, but that's what they used to give. Give epi, give sodium bicarb, give some more epi, give some more sodium bicarb. Really wasn't a good look, right? But that was the game back in the 70s. So it's not a first line medication. There are times when you might use it if nothing else is working. You're working this patient for a long time, and none of the other interventions are working. You could consider maybe that's because they're really acidotic, and defibrillations don't work when the patient's really acidotic. Epi doesn't work when the patient's really acidotic. So I call, if you were giving it towards the end of an arrest to see if you could get any response from anything, I call it the kitchen sink of cardiac arrest. You've already thrown everything else at the patient and nothing worked. We're like, well, we could give a trial of bicarb, I guess, right? But even that has fallen out of favor now. But you will still see some physicians um, as the court of last resort. Nothing else has worked. They can't get the patient out of arrest. They would give them a trial of bicarb uh, at the end before calling the code, right? But more specifically, one of the reasons we might use it in a very particular arrest situation is if the patient is hyperkalemic. And you're going to learn that you can recognize hyperkalemia on the ECG. Um, so that's something to look forward to really soon. And the patient population that I would say would be the most classic patient would be a dialysis patient that missed their dialysis and their potassium is really sky high. That patient is very vulnerable for arrest. So it might be used to treat one of the things used to treat hyper K before they arrest, but it could also maybe be used during the arrest. Although there's another drug that we would give uh, preferentially or give it first. But this is one of the things in cardiology that we think about bicarb for. And how does it work in hyperkalemia? It actually shoves potassium back in the cells. Okay, it floods the zone and shoves potassium with sodium, and it shoves potassium back in the cells. It's got a very rapid action in terms of the pH change in the bloodstream once it's given. Right. So use latent cardiac arrest if at all. We'll find toxicologic reasons to use it, but again, that's beyond our scope for this. We want to stick to the cardiac stuff. So you got your hyper K. And if it's appropriate, there's no contraindications. Obviously, it can shift the pH into an alkalotic state, right? And in the pre-hospital, if it was given as the court of last resort in cardiac arrest, which we're largely even walking away from that now, you would only ever give it once. Any further dosing would be based on blood gases. But when it's appropriately used, no big deal. Now, the medication that would be the first line med in hyperkalemia is calcium. But here's something that you absolutely must know. You cannot mix calcium and bicarb. It will make limestone. Calcium chloride and sodium bicarbonate make limestone. Limestone is calcium carbonate, right? So it literally makes rocks. You do not want to mix these drugs. It will create this precipitate, right? If you've got calcium, maybe you've got outdated drugs, right, that haven't been discarded. If you've got some out of date calcium and some out of date bicarb, squirt them together in a clear glass and leave it sit there and come back and check it for a while later, and you'll find there's a particulate that's deposited on the bottom of the container. It's limestone. So interestingly enough, both of these may be given in hyperkalemia. So what would absolutely have to be done? Flush the IV thoroughly before you'd ever consider giving the other one. Right? Usually calcium would be given first, or maybe have a second line. Hey, there's a good idea. But don't inject one and then go ahead and inject the other. It will make rocks, and that's not a good look for the patient. Right? Absolutely not a good look for the patient. Absolutely must know that. Can't mix those two. Bad stuff happens. Right? Makes rocks. Most of your catecholamines are inactivated by the bicarb, which is why again maybe bicarb was maybe a really bad idea. They also gave calcium back then. Uh, but it will deactivate the catecholamines. So what about dosing on bicarb 1 milli equivalent per kilogram? And further dosing is usually based on blood gas analysis. In extreme hyper K, medical control might want you to give a second amp of bicarb if it were appropriate. But for the most part, we're just going to give one and walk away. And it is 1 milli equivalent per kilogram for dosing. That's core med. Make sure you know that one. Right. Hey, This looks like a good time to take our break. How you doing with things? My hiccups are gone for the moment. I'm pleased to report. Keel. Awesome. All right, when we come back, we'll look at pain management in cardiac patients. So let's get our clock up. Let's take 15. And I'll get some tunes up for us. All right, 15 on's the clock. See you back real soon.
I am Jeremiah Dixon, I am a Geordie boy. Glass of wine with you, sir, and the ladies I'll enjoy. Old Durham and Northumberland is measured up by my own hand. It was my fate from birth to make my mark upon the earth.
He calls me Charlie Mason, stargazer am I. It seems that I was born to chart the evening sky. They'd cut me out for baking bread, but I had other dreams.
Hey, we're back. I forgot how absolutely talented Stevie Ray Vaughan was. What a sad thing to lose him. All right, so let's move on in our search for knowledge. Here's our fentanyl, right? Our opiate analgesic, our preferred one to use in acute coronary syndromes. Some of you may be using morphine, maybe not the best choice, because it interacts with the ADP inhibitors, or Brilinta, which is actually a P2Y12 inhibitor. Bad jube, I'll have more to say about that. So let's just step on past the morphine. But again, what are we looking for? We're looking for analgesic properties. Now, morphine also can make the tank get bigger, drop the blood pressure, more likely to cause nausea and vomiting. So I'm going to move past the morphine and think about the fentanyl. All right. Think about the fentanyl. So it has a much shorter half-life, but it works almost immediately when it's given IV. And again, we're looking for its analgesic properties and also the fact that it has anxiolytic properties, which can stop those circulating catecholamines from beating the crap out of the heart in the patient who's having a big fat MI. It is a very potent drug. 100 mics of fentanyl equals 10 milligrams of morphine. It is a very powerful, but again, shorter acting. It's usually gone in about 45 minutes, maybe some variability depending on the patient. So if you have long transport times, you have to consider redosing, right? And again, let's just stick to the ACS. But here are some things that you'll want to know about this drug. And some of these things are not predictable. Like you can predict that fentanyl could knock down the respiratory drive or knock it out, chill the patient out, maybe lower their LFC, although we're not giving big, huge doses of it. But one of the things that you aren't going to be able just to predict is that it can cause something called stone chest or wood chest. Has anybody heard of that? Stone chest or wooden chest phenomenon? Any takers on that? It's less likely to happen with the doses that we give for fentanyl. It's more common with larger doses. It can happen if the dose is given too quickly, though. We don't want to slam opiates in, right? We push a little, flush a little, push a little, flush a little, push a little, flush a little. We don't want to give it very quickly. That could increase the chance for a stone chest. It happens more frequently for some reason in children. It's more likely to happen with larger doses than we're giving. So what is it? It is literally a patient's, all the muscles in their chest goes into spasm and they cannot breathe because their chest becomes hard as a rock. This is truly a frightening thing. They can use big amounts of fentanyl, and sometimes they may just use it for short surgical procedures and people that can't tolerate anesthetics. It says more likely, saying that surgical situation or post-surge, to see this, and it's another brown pants moment. You definitely wish wear brown pants because it's going to be nigh on impossible to bag the patient because their chest has become hard as a damn rock. Uh, that's the top of my list. That and a prayer, Stephen. Okay, seriously, you're gonna try to bag them through it, but it's gonna be hard as hell to bag them. And yeah, Narcan and praying because stone chest is potentially lethal, right? So with the dosing you're given, you're probably not going to see that, but you do need to know, and I would definitely put that on my drug card, right? Because there ain't no way just to rationalize from understanding mechanisms of action and stuff that you would ever come up with that one. It is an unusual, unique side effect. I'm kind of amazed that you all aren't seeing it on the streets. There's so much fentanyl out there. Has anybody encountered it in an opiate overdose patient where the chest was hard as a damn rock and you couldn't bag them? Because that's where I would think that these days the EMS might encounter such a phenomenon. Sam, you have? You've had the stone chest phenomenon in the opiate overdose? What happened? You don't have your mic set up, do you? I'm interested in your comments. Wish you had your mic set so you could talk and not typing. But I'm interested to hear what you got. And Derek is also typing about something here. So it's a real thing, and it's not good, right? It is not a good look. Why? No, don't be scared of the mic. Come on, Derek. For the love of goodness, don't be scared of the mic. I'm going to want to hear from you guys. I just don't want you broadcasting burps, farts, and lovely phone conversations in the middle of class because you are not paying attention. It's very different than hearing your lovely voices. I want to hear your voices, just not talking to someone else. Well, I'm not saying what you're typing there, Sam. You must be typing a big piece for us. Oh, you are. Let's see. It was laced. You got there, officer started compressions, grabbed the bag right away, started before the medics intubated. I asked them why it was so hard, and they knew all about it. Somebody in the room said they just bought the drug. She tried it for the first and immediately collapsed. Did the patient survive? Did not survive. Yowza. But was already in arrest when you got there. So who knows how long the downtime was, that sort of thing. Yeah. That's an ugly story. Mm, yeah. That's no good either. Terrible. Yeah, that's ugly. All right. Well, we know that these Schedule II drugs have significant abuse potential and so on, and the requirements, we've discussed all of that. Have Narcan standing by if you need it, right? So again, respiratory depression, apnea, and again, it's unpredictable who's going to have, a more profound effect. Um, it's just not predictable based on age, body weight, any of those things. Laryngospasm also happens in addition to wooden chest syndrome. So these are two bizarre things with fentanyl, right? You don't have to worry about rebound respiratory depression. Again, sometimes in patients who absolutely cannot tolerate anesthetics, they might just give a ton of fentanyl to do an operation on them. And fentanyl is fat soluble, so it will bind up to the fat in the body. And we know that fat is one of the reservoirs that can type a drug, right? And then later on, it gets released again. So they can have a rebound blast of fentanyl in their body. Again, with the dosing we're giving, it's not really an issue, right? We're not giving these massive doses. But somebody who's had a massive amount, yeah, later on, the fentanyl can start releasing from the being bound up, and they could go into respiratory arrest again. Okay. Obviously, if there are other CNS depressants on board, these things are very, uh, very synergistic, aren't they? We were just looking at an article that said rock or sucks could break the chest wall rigidity. Yeah, but you would. Yep, exactly, exactly. But yeah, that's thinking. I didn't go there, Riley, because you'd like to avoid that if possible. Narcan has broken it, but does it successfully break it? Not necessarily. In worst case scenario, yeah, snowing them and paralyzing them might be the only thing you could do. That would be the court of last resort. So make sure you know your dosing here for fentanyl. Anybody carrying laughing gas, nitrous oxide. This was a thing for a while, then it phased out. But then with all the issues with opiates, some systems are bringing it back around. Other countries have used it more than we have. But this is a 50-50 mixture of oxygen and nitrous oxide. I'm talking about specifically for pain management and could be used in acute coronary syndrome. But your dentist uses it. Yeah, that's where a lot of you have encountered it, is in dental world. This is a tank of Intinox. Uh, ambulance service uh, used it on you during your accident. Okay. Um, and did it help you with your pain? It usually does. It's usually pretty good. So what you're seeing here is a tank that has a 50-50 mixture of nitrous oxide and also and oxygen, right, in one tank. This tank, you have to invert it several times to mix the gas because if it sits for a while, it'll separate. Yeah, the transport was 40 minutes. Nitrous kept you pretty pain-free for a while with the fentanyl. Yeah. And Derek, you got to a 14-year-old with a knee injury and it worked well. Yeah. But technically, you should have a scavenger system in your truck or make sure that you're venting the ambulance because it's not meant for you to get high on, right? And it is a gas. You're in a confined space. So Nitronox are two tanks with a blender. One tank of nitrous oxide, one tank with oxygen. Intinox is mixed together in a single tank. So here's a blender setup, right? But it's a 50-50 mix. And it is a very good analgesic, right? Again, Intinox tank has to be shaken to mix the gas prior to use because they separate. They have different densities. So it's a good CNS depressant. It's not a core drug for us, but we talked about it a little bit. Again, it has to be self-administered. You never strap the mask on the patient. You have them hold the mask up to their face, and when they forget it, drop it, start laughing uncontrollably, whatever, then they're done. If they need more, they can take more, but it's always self-administered. Right? So it kicks in pretty quickly. It has a very short half-life, which makes it safe. Um, so musculoskeletal pain, burns, these are great things. The dentists use it, right? But it can be used in acute coronary syndrome as well. Who would never get this drug if they can't follow verbal instructions, if they've already got other drugs or alcohol intoxicants on board? Head injured patients would not be getting it. If you thought they had a pneumothorax, let's not fill up their chest with laughing gas. Maybe a bad idea, right? Or severe abdominal pain and distension where gas could leak. Sorry. How long did I mute myself? Just now? Just the last slide? Yeah. I don't know if I said anything. Basically, it's synergistic or potentiates other CNS depressants, right? So self-administration only, and then proper documentation. So that's all I'll say about that, but it's interesting to know it's still showing up in some ambulances around the country. Here's our Lasix, again, largely downgraded in acute pulmonary edema, increases morbidity, mortality rates, and the chance for ICU admissions. But it's still in a lot of protocols. There's still a lot of doctors want you to give it. This is a loop diuretic, right? Not potassium sparing. And this particular container has 40 milligrams in 4 mLs. So it is a potent diuretic. It's a loop diuretic, um, and it works on the ascending loop of Henle. And then there's this urban legend, which is what really precipitated its use for so many years, that it would basically make the venous tank big, which would reduce preload, which could improve the situation in acute pulmonary edema. Uh, but that appears to be an urban legend from everything I've learned. It doesn't generally cause global vasodilation. It may cause it locally to the injection site in the vein, but not body wide. And those studies were done looking at it in the vein where it was injected, not system wide. So that's the kind of crap that sometimes makes it into protocols. For many years, what I was, our protocols were for acute pulmonary edema, nitroglycerin, Lasix, and morphine. Morphine makes the tank big too. But morphine, totally thrown out to the curb for acute pulmonary edema, and Lasix should be, but you're still going to see it used. You're still probably going to see it in protocols. Again, increases morbidity, mortality rates, and increases the chance it's going to be an ICU admit. That's what it does. So there's this whole venous pooling thing that's probably crap, right? The diuresis starts not long after, say 15 minutes. And if you've got a patient who's a Lasix virgin, boy, they're going to produce a tremendous amount of urine, right? And again, that was another thing. Get rid of the fluid, offload the fluid. Well, the acute pulmonary edema patient, the problem is not too much fluid in the majority of cases, right? It's that the fluid's in the wrong compartment. It's collecting in their lungs. But since it's core med, let's talk about it. The vasodilatory stuff, which probably is crap, happens sooner and the diuresis later. It certainly is something you find in med lists for CHF, right? But it's largely been DC'd for APE, right? Because of higher M&Ms, as I just said. But own your Lasix because it is core med. Lasix is got the sulfa, not sulfur, but sulfa. It's just like sulfa drugs or a type of antibiotic. It has a similar molecular component to it. So if someone is allergic to sulfa drugs, they will also be allergic to the Lasix. Those people, because again, this is not uncommonly given to people with long-term CHF. If they have a sulfa drug allergy, instead of Lasix, they'll give them a similar drug, but it doesn't have the sulfa molecule in it, and it's called Bumax, bumetanide. So dehydration, electrolyte depletion over, again, not from a single dose, but it is not potassium sparing. People that are on this chronically will get hypokalemic. If they're taking not huge amounts and they're eating okay, they should be able to address the potassium through foods. Bananas are really high in potassium, orange juice, which those are also very high in sugar. But potassium-rich foods may be all that's necessary for them to replenish their potassium. But if they're taking large amounts of it, then yeah, it can cause a lot of cramping and problems because their potassium is low. And the drug itself is sensitive to light, needs to be protected from light. If it's given in rapidly, and sometimes even not, it can cause ringing in the ears. That's tinnitus. That can be really terrible. So what? Headache, dizziness, hypotension, volume depletion, potassium depletion. Dysrhythmias, that's pretty rare unless it's because of really low potassium. Loose stools, nausea, vomiting, and a very unique thing, and again, often if it's larger amounts are given very quickly, the ringing in the ears, the tinnitus. Shouldn't be given in the same line with amrinone, which you don't carry. It'll precipitate just like mixing bicarb and calcium. And mixed with other diuretics, it can further mess with the electrolytes. When we were giving it more regularly, if the patient was a Lasix virgin, we'd give them 20 milligrams slow IV. If they were taking it at home, we would quote unquote double their daily dose. So if they were on 20 at home, we'd give them 40. If they were on 40 at home, we'd give them 80. And at a certain point, you're not going to keep doubling, right? So we probably wouldn't go above 100, 120. But the old 20 for the Lasix virgin, double the daily dose, was standard dosing for many years. Here's a little bit on the Lasix, the furosemide. Let's look at our nitro, and here's the tablets. Here's the spray, 0.4 milligrams. It's a very potent smooth muscle relaxer, and it's not just the smooth muscles in the coronary arteries, right? It can relax the smooth muscles in all the vessels, which means it can make the tank big, which means it can crap out their blood pressure, which means we need vitals, we need 12 lead, we need an IV. What if you drop their blood pressure, lay them down, open up your line, put their feet up, recover their blood pressure? Obviously, if they've got wet lungs or short of breath, they're not going to tolerate being laid down, but excluding that, you're giving nitro for chest pain and they crash again. You don't have a blood pressure, hit yourself in the head because you should have had one. Lay them down, elevate their legs, open up the line. You will recover the blood pressure in a very few minutes with that. So how's it work? Reduces the workload, dilates coronary arteries. So it may be able to squeak some blood past where the blockage is, right? Certainly can be very helpful in angina, but are we necessarily going to get relief in a patient having the big fat MI? And the answer is no, but we can try. And if they're having a lot of discomfort, I'm not going to give 3 nitros before I go to an opiate analgesic, by the way. Don't need to do it in order like that. Get a nitro going once you're prepared to give it. And if they're not getting any improvement, they're having a lot of discomfort, don't think you have to give 3 before you can give them some fentanyl, right? But we never give more than 3. So it's going to work very quickly, sublingually, right? Half-life is maybe 4 minutes. Right? So angina, MIs, and then we have a much more aggressive way that we use it in acute pulmonary edema, as long as they're not hypotensive. Obviously, we don't give it in hypotension, and we have to be concerned about anybody that's got an insult to their brain, because what is a very common, predictable side effect from nitro? And it's a big wonking headache, right? You'll get a big old headache. And why does it give people a big old headache? Because it dilates the vessels in your brain. Well, that'd be a really bad idea in someone who was bleeding in their brain or had swelling in their brain. So, an increase in the cranial pressure, right? So, if anything you think's cooking up in the head, step away. People who need to take this on a regular basis may take more to get the job done. They can develop a tolerance. And again, with the tablets, every time you open that container and expose it to light and air, it degrades the efficacy of those tablets, which is why, as I told you when we had our Med lecture, I would always leave the tablets with the patient at the hospital and replace the container. Because the last thing you want to do is question whether your nitro was any good, right? Did it not work? Was it not good? Never want to think about that. So headaches, certainly very predictable. Burning under the tongue, very classic. Certainly can cause weakness, dizziness, drop out the blood pressure, um, or cause orthostatic hypotension when they sit up from lying down or stand up from sitting. They can crash their blood pressure out. Some people might get a rash. It can dry the mouth somewhat, and the ever-present nausea and vomiting. Again, people that are on erectile dysfunction drugs, the PDE5 drugs, phosphodiesterase inhibitors, no on the nitro, right? And many protocols will say for if they've had it within 48 hours, because it depends on which one of the phosphodiesterase inhibitors that they took, right? If it's something like Levitra for the weekend warrior, that stuff stays in the system for about 48 hours, right? Alcohol also can increase chances it's going to precipitate hypotension, right? And then if they're on any antihypertensive drugs, it could increase the chance for hypotension. So in our ACS patients, 0.4 sublingual, up to 3 doses, right? Could repeat every 3 to 5 minutes, vitals after each dose. Acute pulmonary edema, more aggressive use of it, right? Certainly want to continue to monitor vitals, but we're actually looking to normalize the blood pressure, reduce afterload and preload. Nitro paste, we're not really using in ACS, but it might be a transition if you have gotten result from sublingual nitro and acute pulmonary edema. Once you've given several doses and you're seeing the blood pressure coming in the right direction, so you don't have to break the seal on the CPAP mask, you could transition to nitro paste, but not as a front line. You'll have medics say, oh, I just put them on CPAP and use the paste. What they've gotten is a result from the CPAP, not from the paste, because it takes a while for the paste to even have an effect, like maybe 20 minutes, right? So it's not the frontline form of nitro. It's 2% paste. Again, it lasts a lot longer than sublingual, but it takes a long time to get going. So its effect is pretty much the same. It's dilating the coronary arteries, right? Can relieve ischemic pain. Again, in acute pulmonary edema, it can act on preload and afterload. But look, onset 30 minutes. So this is useless in the emergent treatment of an acute pulmonary edema patient, right? So for prepping the skin, we talked about how you can take a towel or 4x4 and scrub. You might have to shave the area, scrub, 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 remove the oils, the dead skin, bring the blood to the surface, then apply the appropriate amount that you're delivering, half to an inch, whatever, onto that site, and then put a bio-occlusive dressing or something over it to keep it stabilized and safe. Again, not if there's intracranial pressure increase, and obviously not if their blood pressure is low. And just like the oral sublinguals, tolerance can occur, postural syncope can occur, and yeah, basically the same thing. Probably more likely to cause the rash if it's the topical. And again, avoid it in patients that are taking phosphodiesterase inhibitors. Alcohol, same thing we just talked about, right? And dosing half to an inch. Some places might go up to an inch and a half. An inch of nitro paste is 15 milligrams of nitro. It's a lot, right? What else? Calcium. What drug do we never mix calcium with? No, bicarb. That's it. Some of you may be carrying calcium gluconate, um, but we're going to talk about the chloride. Some doctors think this should never be given through a peripheral IV because if it does infiltrate, man, it'll rot a big hole in you. There'll be a massive amount of die off of tissue. It's very dangerous to infiltrate. So there are docs that think this should only be given through a central line. If you've got a good free-flowing patent IV and you're being appropriate in your use of it, it will be fine. But do recognize, and this is true for a lot of the medicines we carry, calcium is infamously bad, though, I got to say, for rotting a big old hole in you, right, if it infiltrates. Our use in cardiology is pretty slim. Obviously, in the field, unless you use an I-stat, you're not going to know if someone's calcium is low, so we're not giving it for hypocalcemia, right? What is it the opposite of? What electrolyte is the opposite of calcium? When we talked about last time? Mag, yeah. Someone had too much mag, could you give them calcium? Yeah. If they had too much calcium, could you give them mag? Yeah. But the main reason that we will think about it is in significant hyperkalemia. And it's the first line medicine that we think of. Really high potassium can precipitate very unstable cardiac situation and can precipitate cardiac arrest. Um, you'll learn about how you can recognize it, and over time, we'll also learn when it's really high how bizarre it can change the ECG. Um, and calcium, boy, can work. Unlike bicarb, if it's hyperkalemia, calcium does not push the potassium back into the cells. What it actually does is stabilize the membrane electrically so that the conduction system is less likely to misbehave really badly. So it stabilizes the conduction system membranes, cell membranes. Uh, doesn't push the potassium back in the cells. And again, right away when it's injected. Okay. So acute hyperkalemia, this is probably our centerpiece. The other reason we might give it is someone had a really bad result. You gave them diltiazem, way overshot the mark and crashed them out. You give them a little calcium to counteract that, the calcium channel blockade. So here's another use. And we'll revisit that in toxicology for calcium channel blocker overdoses. Right? Because DIG increases intracellular calcium, you want to step away from calcium if the patient's on DIG. Can make them get DIG toxic. Again, if you were also going to give bicarb, which might be the other thing you give, another thing you give in hyperkalemia, make sure you flush that line super good, and ideally have a second line. And then also, as I just mentioned a minute ago, infiltration of calcium, man, disastrous. So much tissue death. It could precipitate cardiac arrest, worst case scenario, but it could more likely cause some bradycardia, maybe even a dysrhythmia. Again, makes rocks if you mix it with bicarb. Don't give it if they're on DIG. And then dosing, in a way, depends on why you're giving it. If you're giving it in significant hyperkalemia, in adults, probably a gram, which is the contents of that container there. But some sources may say half to 1 gram. If you're giving it a calcium channel blocker overdose, you probably don't need to give an entire gram of it, right? Slower dosing, maybe 2 to 4 megs per keg. Let's make the math easy. There's 70 kilos. You're giving 2 per kilo. You'd be giving 140 milligrams. That's a long way away from a gram, right? Or at 4 megs per keg, that'd be 280 milligrams. It's a long way away from a gram. So lower amounts if it was used in a calcium channel blocker overdose or a bad result from the calcium channel blocker. Gram, pretty typical in the patient. And this can't even be given during cardiac arrest. Sometimes they're walking away from that now. But if they arrested from hyperkalemia, the classic dialysis patient missed their appointment and ends up coding on you, hyper-K, probably going to be giving it during the arrest, okay? So, hey, we've done our tour of the meds. We're now going to start on cardiology for real. What do you think about that? Hopefully, we really helped you tune up your drug cards tonight and last time. Get that core information down. So exciting where we're going, folks. Next week. So, what you got to say for yourself? Anything? Are you in a state of near coma-like condition here? Bueller? I do want to hear from you guys. Yeah. Well, that's it. That's what I got. I'm going to start on cardiac anatomy and physiology next time. It's going to be so exciting. Good. I'm glad. Thank you for the feedback, Justin. I'm glad to hear that. All right. Good enough. I've been working on a project on my own. I might be eventually setting up a YouTube channel or something. I'm doing a deep dive on vitamin C, and I'm actually mind blown how many critical functions in the body require vitamin C. That's completely off topic, but I've got a really nice PowerPoint put together on the overview. Wish we had time. I'd show it to you. I'd love your feedback on it. But I thought I knew a lot about vitamin C, and the more I looked at it, it's crazy how many physiologic processes require it. Oh yeah, I get that, and it's got to be given IV. Um, anybody game for hanging out for 10 minutes and let me show you what I've done? No need to do if you don't want to. But if you thought, yeah, okay, cool. You're well positioned to appreciate how crazy cool it is. So I don't have it like loaded in so I can set it up for um, to bring into the classroom. I just have to share my screen, and I won't tie you up for long on it. We'll see what we can do here. Never tried to share it as a full size PowerPoint. See what happens when I go full screen. See if it works. Yeah. All right. So this will be a good test of your understanding of so many of the things that we've worked through so far in class. So here, all right, you can't see that, can you? All right, full screen doesn't work. All right, now I know. So we'll just look at it this way, it's fine. So this is the actual molecule. It's the L left-handed form of ascorbic acid. That's what vitamin C is. Because there's a left-handed and a right-handed form, uh, and it's only the left-handed form that's biologically active. Where is vitamin C and who manufactures it? Well, plants certainly do. Every land plant, right? I mean, we eat plants to get vitamin C, but it's critical for the growth of the plant and also for them to manage stress in any form. So they need it. And most animals can make their own vitamin C. Most animals make their own. And if they get in stress, their body just jacks up the production, right? But we are vitamin C mutants. We do not make vitamin C. We can't manufacture it. We are vitamin C mutants. Us and our closest relatives, the apes and old world monkeys, no capability to manufacture it. We have to consume it. Also, guinea pigs can't make it, nor can fruit bats, interestingly enough, right? I'll bring this down and we'll make this get a little bigger. So why can't we make it? We're missing, we've got a messed up gene in our DNA, the gulo gene. We're gulo gene mutants. And how do plants and animals that can manufacture vitamin C do so? Well, they make it from glucose. But because we are gulo gene mutants, we can't produce this enzyme called, this is a fun word to say, guanolactone oxidase is the enzyme. And you need that enzyme for the very last step of manufacturing vitamin C. We don't have the capacity to do that. We can't make the vitamin C, right? So what are some of the things it does for us? It is a donor of electrons. And for a huge number of processes, biophysical processes, vitamin C is critical for this ability to donate electrons. And this is part of what's called redox signaling. Redox stands for reduction oxidation reactions. This is a hot area of biophysics study, has been for the last few years. It's really opening the world of biophysics in many regards as being probably more important than biochemistry in terms of our electromagnetic life force. So vitamin C can donate electrons. It can donate a couple of them, and it will become oxidized. But when it donates to something, it will reduce it. You learned about reactive oxygen species down in the electron transport chain. Now, when they're out of control, they can fry the mitochondrial membranes, the nuclear membranes, the cell membranes. Well, vitamin C is a major antioxidant. It delivers electrons to those reactive oxygen species, and it takes the fire out of them, right? So there are massive numbers of redox reactions in the body, so many. But if I wanted to break them down into categories, so we could say metabolic redox reactions, immune system redox, DNA redox, and then cell signaling. So let's look at metabolism first. And again, vitamin C is absolutely critical for your mitochondria to be happy, right? The only cells that I know of in your body that don't have mitochondria are red blood cells. Every other cell has them and has to make their own ATP, to be able to stay alive. If your body stopped making ATP, you'd be dead within seconds, right? So you need vitamin C to keep your mitochondria functioning. And in what way? Well, it can neutralize excess free radicals by donating electrons, right? What else? Another major antioxidant is vitamin E. Vitamin C helps your body replenish its vitamin E stores. Also, vitamin C maintains the healthy levels of the master antioxidant, which is glutathione. Critically important. So vitamin C helps maintain your glutathione levels. Vitamin C is necessary to move fatty acids into the mitochondria so they can be burned for ATP. And the vitamin C, because the mitochondria, the electron transport chain, is a many-step process, vitamin C's electron donations keep that machinery running smoothly. Vitamin C is absolutely critical to remove old or damaged mitochondria. Vitamin C is critical for your body to be able to make new mitochondria, and it helps maintain the health of the mitochondria. What about for the immune system? Well, here's some critical cells you learned about back in pathophys. The number of things that vitamin C does to help these cells do their job, be able to replicate, and to maintain their own health is unbelievable. If I just pull up my notes area here, It's crazy all the things that vitamin C does for every one of these white blood cells and the T cells and B cells, the lymphocytes. They would not be functional if you didn't have vitamin C, right? Proliferation, function, and the health of them. Crazy. What about your DNA? Well, we can think about epigenetics, which is the DNA interacting with the environment to make to make the right templates, to make the right substances. So vitamin C actually keeps your DNA cleaned up by this process called demethylation. When things get tagged on your genes, on your chromosomes, vitamin C has a critical role in cleaning up your DNA. It's also critically important to turn genes on, or in some cases to turn genes off, based on what the body needs at this moment in time. It also is critical to help repair and maintain a healthy genome. Are you impressed yet about vitamin C? What the heck, right? Um, what about intracellular communication? So, collagen. Collagen is the most ubiquitous protein in your body. It connects everything to everything. It's not just a mechanical thing. It is an electromagnetic thing. It's piezoelectric, but it's certainly with standard knowledge supplies a lot of structure and support. But it is also a communication route electromagnetically. And where do you find it? Well, it connects everything to everything in the body. Everything is connected to everything with collagen. And outside the cells, there's this very dense extracellular matrix, which you never learned about, although if you took my AMP class, I did mention it. But it kind of gets left out, and it's so important because it does connect everything to everything. And you can't make collagen. Collagen is a triple helix. DNA is a double helix. You can't make collagen without having vitamin C. You can't make good, stable, strong collagen without vitamin C. So it helps every cell in the body communicate with every other cell because it also communicates with the something else you probably never learned about. You might have a little bit if you took my AMP, which is you have a skeletal system inside your cells, the cytoskeleton, which doesn't have collagen, but the components of the cytoskeleton talk to the extracellular matrix. So it means literally every cell in your body is plugged into every other cell in the body with a completely separate communication system than any of the ones you've learned about. And vitamin C is essential to stabilize the cytoskeleton. So when cells are communicating with each other biophysically, vitamin C is essential for shaping that extracellular matrix, for stabilizing the cytoskeleton, for driving those redox reactions. It also is critical for a lot of ion channels. Boy, we learned about those in the cell membrane. Who knew? What about cell signaling with neurotransmitters? The catecholamines. Ooh, you're all over those, right? Check this out. You can't make dopamine, norepinephrine, or epinephrine if you don't have vitamin C. What? That's right. You can't make those critical catecholamines without vitamin C. If you are a chemistry buff, you can look at this image in more detail. But vitamin C, ascorbic acid, L-ascorbic acid is critical to make these substances. Not only is it critical to make epinephrine, norepinephrine, and dopamine, but it actually reduces the sensitivity of the adrenergic receptors so that they more gracefully respond to those neurotransmitters. What about endocrine function? Well, the highest levels of vitamin C are in the pituitary gland, the adrenal glands, and also in the ovaries, in the corpus luteum in the ovaries. In endocrinology, we'll mention the hypothalamic pituitary adrenal axis. Um, Basically, the hypothalamus sits right above the pituitary. It produces hormones that direct the pituitary. The pituitary then releases hormones that talk to other organs. Here, we're specifically talking about the adrenal glands. And so, when the adrenocorticotropic hormone (ACTH) from the pituitary stimulates the adrenal glands, you'll learn all about this in MedEmerge. This is how you release cortisol. We know cortisol is the stress hormone, right? Well, guess what? Vitamin C, if you don't have adequate stores and you start making a bunch of cortisol, you're going to burn through all the vitamin C that your adrenal glands can store. And that's going to make it so you can't handle the stress. So you really need to maintain good vitamin C levels because they can help if you need to release cortisol, but it can also moderate how much cortisol is produced, right? To sort of protect you from excess amounts of cortisol. So here's just a small list: collagen synthesis, powerful antioxidant, cofactor in all kinds of biologic reactions, critical in neurotransmission and neuromodulation, cofactor for an enhancer for many hormones, essential for immune function, preserves mitochondrial function, preserves metabolic function, modulates the inflammatory response, it downregulates inflammation, and protects your DNA. Dang! Pretty cool, huh? What do you think about that? I had no idea how many functions were there. It's way above what I knew. I knew about some of it, but do we now have a deep, deep, deep appreciation for this stuff? Well, standard medicine really has really low amounts. Um, And again, they'll say things like, "Oh, there's been studies where if you're starting to get sick, it doesn't really make a difference if you're already getting sick." Um, but for oral consumption, some people, they'll get. It depends. I use sodium ascorbate, which won't give you the squirts and stomach ache. So if I have to take a bunch, I can. If I need to take several grams in the course of a day, but a gram or two a gram a day, especially if you don't have to do it every day. But sodium ascorbate, it's easier on the stomach. Um, but if you're not getting enough in your food, and I'm going to do another one. We're going to look at sepsis. And when people get really sick, they become like completely devoid of vitamin C. Their body burns it up. So there's a lot more to be said about it. I'm going to do a several part series on this, and maybe one day I'll have a YouTube channel when I grow up. But yeah, so 500 milligrams a day, a gram. Um, there's a brand you can get on Amazon, and it is I think it's called Nutribiota or something like that. It's sodium ascorbate. It's the sodium salt of vitamin C. Um, but and again, none of us are good at this all the time. But you're in a high stress. Your paramedic school is high stress. Your workload is high stress. You burn through this stuff, right? And something to think about. The ascorbate is not a bad way to go. The sodium ascorbate. But again, what Steve was talking about for cancer, that's given very high doses IV, and that's actually looking not for antioxidant but for oxidant properties. Um, it's kind of flipping the switch in sepsis, and I'll get into this much later when we study it. There's certainly a role there that they have done the best to bury, but it's like septic patients are basically in scurvy. Like they're so deficited, they've just burned through everything. So it can be important to fuel so many parts of your body. I'm blown away by all of the things. I mean, I knew probably a third of those things, but now I mean, the more